Welcome to this explainer. Today, we're unpacking something you're going to see literally every single day in clinical practice: catheters. We use them constantly, right? So, we're going to break down the highly testable complications of urinary, central, and cardiac catheters. And we're tracking these risks across the entire lifespan, from the tiniest premature neonates all the way up to our geriatric patients. Let's get into it.
It's really easy to look at a catheter as just a simple plastic tube, Just a necessary life-saving conduit. But the reality? They act as direct vectors for some lethal and highly testable complications. The second we breach the body's natural defenses, the clock starts ticking on a whole host of risks, from nasty infections to traumatic injuries and even metabolic derangements.
All right, here's our roadmap for the day. We're grouping these complications by catheter type. We'll start with urinary catheters and CAUTI, then hit Foley contraindications and trauma, move on to central lines and CLABSI, explore cardiac and neonatal catheters, and finally wrap up with prevention and management. This structure is going to give you a rock-solid mental map for the wards and the boards. Let's kick things off with Section 1, urinary catheters and CAUTI.
We have to start with the most common indwelling device you'll see on the floor, the urinary or Foley catheter. The absolute classic complication here is CAUTI, or catheter-associated urinary tract infection. This drives a massive chunk of hospital-acquired infections. And listen, once a patient has an indwelling catheter, you're not just dealing with your run-of-the-mill E. coli anymore. You really need to be on high alert for specific aggressive bugs. For instance, organisms like Pseudomonas aeruginosa become incredibly frequent drivers of CAUTI, especially after urologic procedures.
Now, what's truly fascinating, and you definitely need to know this, is how differently this presents depending on the patient's age. A classic UTI in a younger adult, they're going to have localized symptoms, right? Dysuria, urinary frequency, urgency. But look at the geriatric side. Elderly patients frequently don't, or literally just can't, report urinary symptoms. Instead, they present with sudden altered mental status or delirium. So if an elderly patient suddenly becomes acutely confused, you absolutely must suspect urosepsis or CATUI. It's a huge clinical pearl.
Let's pivot to a totally different kind of complication. We often use Foley catheters therapeutically to relieve acute urinary obstruction. But paradoxically, when you relieve that blockage, it can trigger a massive release of urine. This is called post-obstructive diuresis, and it's a super testable physiologic response. Because your patient is suddenly dumping massive amounts of volume, you have to watch them like a hawk and aggressively replace that output with hypotonic fluids. If you don't, you're looking at severe volume depletion and nasty electrolyte derangements.
All right, moving on to Section 2, Foley contraindications in trauma.
Let's see how all this applies to a high-stress emergency trauma scenario. Replacing a urinary catheter is actually strictly forbidden. Picture this. A trauma patient rolls into the ED after a high-speed car crash or a bad straddle injury. Before you even think about placing a Foley to monitor their urine output, you have to look for red flags. We're talking blood at the urethral meatus, perineal ecchymosis, a high-riding prostate on exam, or a scrotal hematoma. If you see literally any of these signs, it points to a severe urethral injury, often involving the posterior urethra if there's a pelvic fracture. Blindly placing a Foley here, you could push right through the tear and create a devastating false passage or permanent strictures.
So here's your crucial algorithmic sequence. Step 1, notice the signs. Step 2, halt the Foley insertion immediately. Do not pass go. Step 3, perform a retrograde urethrogram. You'll gently inject contrast into the urethra to check for any extravasation. Only after you know the exact location and pattern of that injury can you actually make a proper plan, which often means surgical repair or suprapubic catheter instead.
Okay, Section 3, central lines and CLABSI. Leaving the genital urinary system behind, let's explore the really high-stakes complications tied to central vascular access. Central venous catheters are lifesavers for pushing pressors, long-term antibiotics, or nutrition, but they carry the dreaded risk of CLABSI, central line-associated bloodstream infection. This is one of the top causes of hospital-acquired sepsis. The longer that line sits in a vein, the higher the risk goes. And we aren't dealing with benign bugs here. We're often fighting Staphylococcus aureus and Staphylococcus epidermidis, which can rapidly snowball from a simple bacteremia into a devastating endocarditis that seeds the heart valves. And this right here perfectly illustrates a classic clinical vignette you're absolutely going to see on the wards and on your exams. Imagine a 51-year-old patient who's been on total parenteral nutrition, or TPN, through a left subclavian central catheter for weeks after abdominal surgery. Today, he spikes a fever to 38.4 degrees Celsius, and his white count shoots up. A patient on TPN through a central line with a new onset fever is at a uniquely high risk for not just bacterial sepsis, but fungemia. Candidemia absolutely thrives in that high glucose TPN environment. So, what's the game plan? When you suspect a central line infection, you have to follow a strict diagnostic sequence to confirm it. First, draw blood cultures directly from the catheter site. Second, draw a second set of aerobic and anaerobic cultures from an alternative peripheral site. This is key to differentiating a true bloodstream infection from just simple line colonization. After you've drawn the cultures, you start empiric broad-spectrum IV antibiotics immediately. And finally, in almost every single case, you have to remove the infected central line to actually achieve source control.
Aside from infections, central lines can also cause physical trauma. They can puncture vessels or the pleura during insertion, leading to a pneumothorax or hemothorax. But check out this fascinating, albeit rare, complication: extravascular migration of the central catheter. If a line migrates into the pleural space while lipid TPN is running, and you perform a thoracentesis to check out the new pleural effusion, the fluid will literally look milky. Even wilder, if you check the glucose, the pleural fluid to serum glucose ratio will be greater than 1.0, simply because you're pulling back the exact nutrition formula you just infused. Crazy, right?
Moving into Section 4, cardiac and neonatal catheters. Let's examine some specialty access routes. When cardiologists thread a catheter through the femoral artery all the way up into the aorta to reach the heart, the actual mechanical scraping of that catheter against the aortic wall can dislodge atherosclerotic plaque. This sends a literal shower of cholesterol emboli downstream. This microvascular blockade causes a very distinct syndrome. You'll see acute kidney injury, bowel ischemia, and this very characteristic lace-like purplish rash on the lower extremities called livido reticularis. Also, because these cardiac patients are heavily anticoagulated during the procedure, you have to watch that femoral access site like a hawk. If your post-cardiac cath patient suddenly complains of severe back or flank pain and you see their blood pressure dropping, that is a massive, screaming red flag for a retroperitoneal hematoma. The arterial puncture site is basically bleeding backward into the retroperitoneal space, and it can hide liters of blood before you even realize what's happening. Now let's flip to the very beginning of the lifespan. In the NICU, umbilical venous catheters provide incredibly fast, essential access for critically ill newborns. But premature infants have highly immature immune systems. This gives them a severely heightened susceptibility to overwhelming, rapidly fatal line infections. And to touch on one very specific, very heavy clinical protocol, while these lines are amazing for resuscitation, if a newborn demonstrates clear clinical evidence of death, it is strictly inappropriate to place an umbilical venous catheter just to push epinephrine as part of continued resuscitative efforts. Finally, Section 5, Prevention and Management. Let's consolidate the core rules for preventing these iatrogenic disasters across all age groups. Look, the ultimate management strategy in medicine is just aggressive prevention. Every single day on rounds, you've got to ask, is this catheter still strictly necessary? Getting rid of physical tethers like urinary catheters early doesn't just stop infections, it's actually a primary protocol for preventing delirium in hospitalized adults. You want them out of bed, mobilizing, and completely free of tubes. Also, never ever place a Foley catheter simply to manage basic urinary incontinence for nursing convenience. The infection risk is just way too high. Which leaves us with this final critical thought to bring to your daily rounds. You have to ask yourself, is the convenience of that tube really worth the potentially lethal complications we just explored? Whether it's a neonate with an umbilical line, a 50-year-old on TPN, or an 85-year-old with a Foley, challenging the necessity of these devices every single day is exactly how you save lives. Thank you so much for joining me on this explainer, and I'll see you next time as we keep breaking down the complexities of clinical medicine.